All right, we're getting ready to start.
It's a little warm.
But over the last 3 or 4 weeks, we've done a series of presentations related to cases that were childhood experiences, childhood trauma, resiliency, and Dr. Wolfe is going to kind of put this all together for us and bring forward an opportunity for us to participate in what's going on in our community. And so all of our graduating residents need to do grand rounds and experience and stuff.
All right. Can everybody hear me? All right. Good morning. I'm Tierney Wolfe. I'm one of the third-year residents, and I'm going to be talking about adverse childhood experiences and what we can do as pediatricians. First disclaimer, I have no relationship to this industry. I'm not making any money today. So my objectives. First, I want to define adverse childhood experiences so we all know what we're talking about. Then I want to talk about how the long-term health outcomes of adults are affected by their adverse childhood experiences. And I definitely want to eventually discuss screening tools and what we can do locally to help our kids here in Shreveport. Another disclaimer. I know everybody in the audience is sitting here thinking, Tierney, this is the third lecture we've had on ACEs in the past 4 weeks. This is probably the 4th or 5th during our residency. Why are we talking about this again? We're kind of just beating a dead horse, it feels like. But the short answer basically is because it's that important. There's all kinds of research that shows how childhood experiences affect adulthood and affect kids and their health, mental health, physical health, all of it. It's all affected by the childhood experiences, so that's why we're talking about it over and over and over again. Okay, so we can't start talking about ACEs without first talking about the Adverse Childhood Experience Study, or the ACEs study. This is a study that was done in the early 90s, published in 1998, done by Dr. Vincent Felitti of Kaiser Permanente in San Diego, California, and Dr. Robert Anda of the CDC, along with all their colleagues. They collaborated and they did this huge study where they surveyed nearly 17,000 adults about their childhood experiences. They asked about 10 different categories that have to do with household dysfunction, abuse, and neglect. And then they took those surveys and gave them what's called their ACE score. So your score is going to be anything from 0 to 10, depending on how many of these adverse events you had during your childhood. Then they took that score and they correlated it with long-term health outcomes. Okay. So what am I talking about? Sorry, that's my page, I think. So what am I talking about when I'm talking about ACEs? There's 3 kind of big umbrella categories. So the first one is household dysfunction. So we're asking questions about things like substance abuse. Anyone in the family using anything, using illicit drugs or have a problem with drinking. Then there's mental illness. Anyone in the family ever attempt suicide? Anyone have a mental illness? Anyone dealing with depression? Specifically parents. Violence towards the mother. So are the kids seeing their mother being hit, slapped, threatened with a knife, threatened with a gun? And criminal behavior. Anyone in the family been incarcerated? And then parental divorce or separation. And then the other 2 big umbrella categories, abuse. So we're talking about physical, sexual, or psychological abuse. And neglect, physical or emotional neglect. So those are the ACEs that they talked about. And then there's 2 really big takeaways that I want everyone to, if you learn nothing else today, the 2 big takeaways that I want you to get from this study. The first one is that ACEs are really, really common. If you look at the results of the ACE study, nearly 2/3 or 64% of respondents had at least one ACE. 12.5% of people, so 1 in 8 people, had at least 4 or more ACEs. So if we go back to this list, think about that. Kids had at least 4 of these things happening in their household. Any one of these would be absolutely terrible, but it's over here. Sorry, hold on. Thank you. Been paged like once in the past 2 weeks, and then of course during this. Anyway, so any one of these things would be terrible, but 1 in 8 of these respondents had 4 of them. And then the other statistic that I thought was interesting was that for people reporting any single ACE, the probability that they had another ACE going on in their household was anywhere from 63 to 95%. So if you've got one of these terrible, stressful things happening in your house, you're more likely to have another one as well. So another way just to look at how common ACEs are, this broke it down by question or by category. A couple ones I want to highlight. First, physical abuse. 28% of children or of adults said that they were physically abused as a child. A close second is substance abuse. 27% said that they had adults abusing substances in their house. And then third, 23% had separation or divorce of their parents. But if you look at all of these, I mean, they're all pretty terrible. 21% said they were sexually abused. Nearly 20% said there was mental illness in the home. Over here, looking at neglect, 1 in 10 were physically neglected. 15% were emotionally neglected. I mean, none of this is good. It's all terrible. So that's the first big takeaway. ACEs are really, really common. Second big takeaway, I want you guys to know how ACEs affect health in adulthood. So this is nowhere near an exhaustive list of the outcomes that they've looked at and how ACEs affect them, but this is a pretty good place to start. So basically what it showed is that as the number of ACEs increase, so you have more of these adverse experiences in childhood, your health outcomes, your likelihood of having these poor health outcomes dramatically goes up. So, I mean, just look at this list. We're talking about things like alcoholism, COPD, depression. Some of the ones I want to highlight, ischemic heart disease. So the number 1 killer of adults in America, you're 3.5 times more likely to develop ischemic heart disease if you have 4 or more ACEs. Over here, suicide attempts. You're 12.5 times more likely to attempt suicide if you have 4 or more ACEs. And then, you know, as pediatricians, there's a ton on here that we really, really need to focus on. Things like poor academic achievement, adolescent pregnancy, early initiation of smoking and sexual activity, illicit drug use, fetal death. I mean, all of these are affected by ACEs, and that's crazy. So you have a little trauma in childhood, and then you develop all of this or some of this. I don't know. It's pretty impressive. Another way to look at it, this is basically just a graphic representation of what I was saying, that as your ACEs increase, so does your likelihood of the poor health outcome. And this is sort of just a generic slide because you can pretty much put any one of these poor health outcomes on this graph and you're going to see the same pattern. This was shown over and over and over again in research that no matter what poor health outcome you're looking at, if your number of ACEs increases, so does your likelihood of developing that poor health outcome. So I have to thank Dr. Farrell for this. She sent me this, and this is a great representation, just looking at the attributable risk of the proportion of health outcomes that can be attributed to ACEs. So looking over here, we're looking at things like HIV, anxiety, mental health treatment, hopelessness, mental health. And you can see that a huge proportion of that can be attributed to ACEs, like up to 67% of life dissatisfaction can be attributed to ACEs. But then over here, we're also looking at things like cardiovascular disease and cancer. 25% of those you can attribute to ACEs, so pretty impressive. So that's the second big takeaway. ACEs affect long-term health. So they're really common. They affect our health. So before the ACEs study, this is kind of what people thought. people had these high-risk behaviors. These high-risk behaviors led to disease and disability, and this led to early death. Well, after the ACEs study, thinking started shifting, and this is known as the ACEs pyramid. Basically what it's showing is that adverse childhood experiences will lead to disrupted neurodevelopment. This disrupted neurodevelopment, you can't think clearly, you can't interact clearly, your cognition is all disrupted, your impulse control is disrupted. That's what leads to this adoption of these high-risk behaviors, then disease, and then early death. So this is the original ACEs pyramid. Recently, they've actually added 2 more layers, and we're talking about, generations and historical trauma, and then social conditions. So basically, what that is showing is that this is no longer just, one dysfunctional family leads to one dysfunctional child. It's generations and generations, and if you look back, it's over and over. Judge Matlock, he's one of the local juvenile judges here in Shreveport. He was talking about, if you look at the kids that he sees in the juvenile system, and then you look at their moms, their ACEs scores are basically 1-to-1, which is, it makes sense. If you grow up and you have all these terrible things happening, that's the behavior that's modeled, that's what you know, that's what's going to happen in the home. So how does this stress affect neurodevelopment? Why does it cause this? So there's a couple things that, there's a ton of studies out there that have shown why. First thing we're going to talk about is the different types of stress. I realize I'm talking to a room full of physicians, so we're all very well versed in stress, but there's 3 different types we want to talk about. So in the context of childhood, there's things like positive stress. So you think about a kid getting an immunization, starts crying, hurts for 10 seconds, they're consoled by a parent. That's a positive stress release. So it teaches the kid, okay, I'm stressed, now I can soothe myself or be soothed by a supportive parent. That's actually positive for brain development. Tolerable stress, this is something a little bit more long-term stress for a childhood. So think of the death of grandma or something like that. You're going to be very stressed out, you're going to be very sad, but with a supportive parent, any disruption in neurodevelopment can actually be reversed. So you have a supportive parent, you get over the relatively short-term stress, no harm, no foul. Then there's something called toxic stress. Basically, with kids with chronically elevated levels of cortisol and epinephrine, it actually disrupts the neurodevelopment. So these are kids that are being chronically abused, chronically under just high-stress environments. Their home is not safe, their school is not safe, they're just chronically stressed out. So basically, just to summarize the huge amount of research that's out there, they've looked at the effects of chronic activation of the hypothalamic pituitary adrenocortical system. I practiced that like 10 times last night. The HPA system. So one of the things that it does is it actually disrupts the regulation of the glucocorticoid receptor gene, actually making a person's brain and body more reactive to stress. So it lowers the threshold for our reaction to stress. So if you're chronically stressed out as a kid, you're likely to be chronically stressed out as an adult because your body is adapted to actually respond better to these hormones. The myelin basic protein gene is also downregulated. So basically we're not myelinating our brain the way that a kid that's not under this chronic stress would myelinate their brain. So you're actually slowing your cognition. And then there's damage to the hippocampus. So damage to the hippocampus, there goes your memory, there goes your learning. So these kids have difficulties with learning, with memory. Their cognition is slow. They're more reactive to stress. I mean, we're basically setting them up for bad outcomes. These kids often present with symptoms of ADD or ADHD, and I mean, that makes sense why they're having difficulty in school, because their neurodevelopment just isn't isn't going the way it should, basically. Research has been done, though. There is good news. With the support of a sensitive and responsive parent, they've actually shown that kids that are otherwise pretty prone to tantrums and things like that, their cortisol levels will be lower in the presence of a supportive, responsive adult. So, if we teach these parents kind of how to soothe their kids, how to help their kids through stressful situations, we can maybe tamper some of these effects. Okay, I'm going to take a little breather and let you guys watch a video. Let me pull it up. So this is basically just a quick little recap of the ACEs study. You can see Dr. Felitti and Dr. Anda, the two major guys that did this ACEs study. So here we go.
Rob and Vince then began a collaboration that's ultimately become one of the foremost epidemiologic studies of long-term health impacts of child abuse and neglect.
I think the most important thing that contributes to the information of the ACE study is simply the powerful nature of when people tell you the truth about their lives and you listen, you understand their life course.
It's made me realize how much of what we see in adult medicine is the result of what was present but not seen in pediatrics.
ACEs changed the landscape, and I want to talk a little bit about how and why they changed the landscape and how we can take what we've learned from the ACEs.
It's just not a social worker's problem. It's just not a psychologist's problem. It's not a pediatrician's problem. It's not a juvenile court judge's problem. It's everybody's.
It changed the landscape because of the pervasiveness of the ACEs, the huge number of public health problems, expensive public health problems, depression, substance abuse, sexually transmitted diseases, cancer, heart disease, chronic lung disease, diabetes.
As the ACE score goes up, the likelihood of chronic, self-acknowledged chronic depression goes up, so that at ACE score 4 or higher, you're bumping a prevalence of 60%, 60% in women and about 35% in men.
This is the percentage of people that ever smoked cigarettes, and here's the percentage of current smokers. Again, we could switch the titles on these slides now. You wouldn't know which was from the Kaiser Health Plan and which was a general population sample in Washington.
So how do those people, without the conventional risk factors, end up with coronary disease? We have used this over an 8-year period with 440,000 adult patients.
I believe that this is the most important thing you can ever do, which is begin to deal with this intergenerational transmission of adversity that causes so many problems in our society.
Oh, I went all the way back. Hold on. Okay. Okay, so that was basically the summary of the ACEs study. Sounds pretty disheartening when you hear it all, but we can help. We're pediatricians, so this is what we do, right? So what can we do? First of all, we have to screen and identify these kids. If we don't know which kids are at risk for having high ACE scores, there's nothing we can do. Dr. Cooper, Dr. Bocchini, Dr. Farrell, and I, we've all been trying to come up with the best way that we can start screening in our pediatric clinic. So we're going to start doing a couple different things. I'll talk about that in a little bit. But we're hoping to start screening every kid that comes to our pediatric clinic. We have to offer support. So if we identify these kids, it has to come off as a very non-judgmental, we're here to help you kind of tone. We're asking very sensitive questions of these parents, so they need to feel comfortable to respond honestly. And then once we identify these kids, we need to refer and connect them to local resources. This is not something that can be fixed in our 15-minute patient encounter. This needs global, wraparound care of these children. Okay, so the AAP and the CDC recommend that we screen kids, but there's no official way that they're saying is the best way to screen kids. So there's been a lot of talk of sort of what to do. So you can do something simply by just asking 1 or 2 questions during the exam. We don't know what's best. Should this be a written questionnaire, or should this be something that's verbally communicated during the exam? Does this need to be just part of the nurse's screening questions, or does this need to be physician and parent? We haven't really found the best way to do it. If you are just going to ask 1 or 2 questions, some of the questions that have been sort of suggested to ask is something like, has anything bad, sad, or scary happened to you or your kid since we last saw each other, or within the past year? That kind of covers a lot of the ACEs without directly asking. Of course, if they answer yes, then you need to explore that a lot further, but that's a good kind of general screening question. Then there's something called the Safe Environment for Every Kid survey, or the SEEK survey. This seems to be one of the best surveys it screens for all kinds of things, not just specifically the 10 ACEs, but it also screens for food insecurity, and kind of it starts off kind of light and then gets into the more difficult questions. I'm actually going to go through it because I think this survey, or or a modified version of the SEEK survey, may be what we start using in our clinic. The other questions we don't really have answers to is how often and who do you screen? I mean, do you screen a mom when she comes into you for the first time and you have no relationship whatsoever? Do you wait until the kid's 2 or 4 months old? Do you screen at every single well child visit, or, just every 6 months or so? We don't really know yet. Ultimately, what we need to do, we're here in residency, we're going to do what the program asks of us, but ultimately, we need to find a way when we get out in practice to screen and what works for our practice. So if it's you asking specifically to the parent, or if it's a questionnaire, you got to figure out what works, but you do got to start screening. So this is the SEEK survey that I was talking about. I know you guys can't read it. I just wanted you to be able to see. It's a 1-page survey. It kind of starts out up here with this little intro saying, being a parent is not easy. We're here to help. Please let us know if there's anything we can do. We're worried about your child's safety. And then it goes into these questions. So like I said, it starts off easy. It asks about poison control, smoke alarms, anyone smoke around your kid. Then it goes into things like food insecurity. So there goes our food insecurity screen, which all the third years know we've been trying desperately to start screening for this year in clinic. That didn't go so well with our advocacy work this year. But if we do include this SEEK survey, then there goes our food insecurity questions, and we can get those in as well. Then it starts going into some of the more difficult questions. So is your child difficult to take care of? Do you ever feel the need to slap or hit your child? Do you wish you had more help? And are you under extreme stress? So that kind of gets at that, those parents that are really on edge and are having a difficult time, quote unquote, controlling their kids. So we can offer them some support there. And then asking about parental depression. This gets more into the household dysfunction. So have you and your partner fought a lot? Has your partner threatened or hurt you? And then ask some substance abuse questions. And then it leaves it open at the bottom, kind of, is there anything else we can help you with today? So this or a version of this may be what we start doing in clinic. It's kind of that good progression of we'll start off easy, then we'll get into the hard stuff. So if this screen comes back and mom's like yes, 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 then what do? We need to. This is sort of just the general outline of what needs to be done about kids with high ACE scores. So this is from the CDC. Basically, a lot of it is parental support. So home visits, support for teen pregnancy, parent training programs, social support for parents, things like mental illness and substance abuse treatment for parents or for kids, high quality child care, let those kids get out of the house for a few hours, just having a mommy's day out, the toddlers leave for 4 hours, 3 days a week, gives mom a good break. So that's kind of the general outline of what needs to be done. But what can we do here in Shreveport? So a lot of these resources are there to help our parents and to help our kids, and we don't really utilize them. So, or at least I didn't. I can't speak for everybody. Things like parental support groups here in Shreveport. We're actually going to have a talk about this. Renee Taylor is our contact for these two programs, and she's actually coming on the 23rd to give us a morning report and teach us more about these programs. But two really good programs. Nurse-Family Partnership. This is for first-time moms. They start at when they're less than 29 weeks pregnant, and they get this weekly visit from a nurse. The nurse will go in, teach them basic parenting skills, help them set goals and achieve those goals. They can refer them to any resources that they need. And one really important thing, they make sure that they go to their OB visits. So we get these babies, or they get these moms good prenatal care. After 2 years old, they can do something called Parents as Teachers. Basically, parent educators will go into the home and they'll work with the entire family. So mom, dad, grandma, grandpa, aunts and uncles, kind of teach them basic life skills, basic parenting skills. And then they'll also work with the children to help prepare them for preschool or for Head Start. So this is a great parenting support group. There's other support groups, we have the Team Mom support group. There's something called Triple P Parenting, which actually has research behind it that it will actually decrease incidents of child abuse. I just didn't put the contact stuff up there, but there's all kinds of things available here in Shreveport for parental support. Other things that we need to do to help our kids are early childhood education and high-quality child care. I just highlighted a few of the ones in Shreveport, but there's definitely more. I didn't know this, but the Providence House actually has child care available for very low-income or homeless children. There's something called Supportive Integrative Services. This is has a Reach for the Stars mentoring program that actually helps mentor kids that have incarcerated parents. So incarcerated parents is one of the big ACEs, so the fact that we have a program that specifically targets those kids is great. And then, of course, Head Start. I think we're all familiar with Head Starts. We do about 10 Head Start physicals a day come July and August. There's something called Early Head Start that kids can go to up until 3 years of age, and then regular Head Start is 3 to 5. It's basically preschool for low-income kids here in Shreveport. There's also, so these are just a few. Of course, Laura Alderman has taught us about the pilot program at J.S. Clark Elementary School, where they're doing yoga with these kids, and they've got the mentors coming in, and they're doing all kinds of great things for these kids. So there's all kinds of different mentoring programs, after-school programs, early childhood programs. We just have to look for them. And then counseling services. A lot of these kids that come in and they're requesting, ADHD medicines, like I was saying before, that's how they present. Well, a lot of them, what they need is counseling services. They need help working through what they've got going on in their life. So we've got a pretty good list of counselors in Shreveport that accept Medicaid, but I just wanted to highlight a few of them. A Center for Hope and Change This is for kids ages 4 to 21. It provides what they call a wraparound approach, where they get services in the school, in the house, and in the community. Changing behaviors. This is just general counseling. I think we've all probably referred at least 1 or 2 kids here. This starts at age 4. There's something called Child and Adolescent Response Team, or CART. This is crisis counseling. This will help the whole family through any sort of crisis. So this is emergent counseling. They help stabilize the family, and then they can refer and act as advocates for that family. Elated counseling services. They specialize in play therapy, art therapy, substance abuse, marriage and family therapy. And this is for kids 3 or older. So that was one of the younger ones I could find. Most of these are from, where'd it go? So we were sent this. I'm not sure how many of you actually looked at this. This is from the juvenile court, and this is basically a pretty thorough list of all these resources available here in Shreveport. It was sent to us on March 8th in the weekly newsletter. I'll ask Jessica to send it out again this week. I highly suggest saving this, looking through this, and knowing the resources. And if you look, this column is, do they accept Medicaid? A lot of them say yes. If they say no, a lot of it is because you don't need Medicaid to go there, but it's not that they're going to have to pay for it. But all these are all counselors that accept Medicaid. So this is a great list. This is a really good resource. I called several people on this list, and that's how they ended up in the presentation. They're really good, helpful resources for our kids here in Shreveport. Okay. So that's kind of just a quick summary of some of the things available in Shreveport. I could go through that whole list, but we would need the whole morning, so let's just move on. Basically, what we want our parents to know when they leave this office, if they're screened for a high number of ACEs, we want them to know this. They're not alone. We're here to help. It's not their fault. What can we do? So we need to offer support and offer resources when appropriate. All right, my take-home message for you guys, basically, I want you to know ACEs are incredibly common, and they have very significant effects on long-term outcomes. We need to start routinely screening our kids, and we are going to do that. So we're going to help identify patients with high ACE scores. And then once identified, these patients need to be given the information and the resources that they need. So that's basically it. I'm going to ask Clay Walker. He's from the juvenile court or juvenile system to come up and just give a quick little synopsis, little talk, if you don't mind.
I don't mind at all.
Okay.
Laura's going to join me.
Okay.
So my name is Clay Walker, and I run juvenile court for Caddo Parish. And I've actually got an updated version of this. We added a Spanish-speaking section for culturally relevant programs for the Latino community. So I'll send that. Dr. Wolfe will figure out where I send that to get that updated. But so we have that updated. The bottom line in terms of the interaction, to some extent this started in juvenile court because Judge Matlock, he does all the abuse and neglect for Caddo Parish. And he starts to see what Dr. Wolfe was talking about, the just generational cycle where he's been doing this for 24 years. So now the child that was the abused child is the parent in abuse and neglect court. And when he started to see that pattern, I think looking into the research, he's looking for what he can do to stop that. And the ACEs study is a lot of, I think, what instructed him on that. On the delinquency side, I deal with the delinquency side. You see a similar pattern. About 120 kids a year. We deal with about 4,000 kids, but 120 kids a year that are just chronic repeat offenders, and that's their childhood. And frankly, what we've, in the same way that Judge Matlock is seeing this generational pattern, what we're seeing is and I don't mean to be negative about this, but it feels like we're too late. For these 120 kids with this cycle, the abuse, and they meet us at 14, and the HPA system, the impact of that, the myelin and the cognition differences, it's almost like we're too late. And so the good news was we've got a very low recidivism rate. It's only about 120 kids. There's 64,000 children in Caddo Parish. About 120 are in this chronic cycle. But we really recognize that there's medicine behind why we're too late. And so that's why we're trying to interact, I think, with the medical community. You all also have a better relationship than we do. No matter what the judge does, a magnificent Oscar-winning speech from the bench, he's still a judge in a black robe that's kind of intimidating and scary. That's not the relationship and the connection you need to meet with a family, meet them where they are, and say, I want to help you. No matter what he does, he's still that judge. A pediatrician, you've got that relationship, you've got that trust with the family. I do think we're going to be running into some problems, when you do that screening. If you ask, have you had trouble, or do you feel like, whatever the question was, do you feel like you need to hit your kid to control them? That is a giant, you're going to call child protection red flag if I say yes, so I'm not saying yes even if the answer is yes. That's what we've got to figure out is, how do you have a conversation with a family where you're saying, what's behind this question is health. It's not going to be child protection and police, although obviously you're mandatory reporters, so you're going to be calling. That's what we've got to figure out is, how do you do that well, maintain the trust in the community, because if the word gets out that you are just going to be calling child protection, that'll shut down your screening. So that's part of what we got to figure out. There are several agencies in town, our detention center, our probation staff. We have a thing called a misdemeanor referral center. If you get picked up for a misdemeanor, a low level, a school fight, a shoplifting, I don't want you to come to detention and hang out with armed robbers and rapists for 3 weeks. Misdemeanor referral center, you get picked up by the police, brought there, and you go home the same day. But they are doing an ACEs screening. So I think in the places that are doing ACEs screenings, we might convene a meeting to sit and talk about what works and what doesn't. What questions are the obvious red flags of child protection? You're not going to get the answer.
Maybe the way that question's worded does not compel a phone call, because I think it said, do you feel like you want to hit your child and control their behavior? That's sort of a mindset of corporal punishment. You're not like admitting as a parent that there's been this episode of bruises, and although you may visually see that as the physician, but I'm not sure that the way that question is worded would compel a phone call. But that'll be certainly up to y'all.
And I think the critical part of that is, how does the mother feel?
Yeah.
What the answer to that question, if she feels like that's going to be a phone call, you may set it up in a way that the physician doesn't have to call, but the follow-up questions behind it.
Yeah. I would say virtually every parent would say yes to that question at some point in their experience, their frustration with, getting their children in line.
You get your child, it's legal in all 50 states.
Yeah.
So you can simply say, it's legal to get your child in all 50 states. We don't encourage it. The American Pediatrics doesn't encourage it. But if you're having to do that, we feel that there may be something that we can do to help. It doesn't have to be an abuse kind of situation, because the truth is they can hit their kids.
Right.
They can hit the kids in the grocery store, they can do whatever. I mean, that's the law. We just don't encourage it. So I think you can say it in a way that just says, we understand we just don't want you to get that frustrated. We want to help.
So the other things that are going on that Jeff Matlock has got in play, there's about 8 different levels of this. There's developing evidence-based practices, reaching out to the mental health community and saying, what evidence-based curriculum do you need training in? Trauma-focused cognitive behavioral therapy. We got a $70,000 grant, and we trained 30 practitioners in that therapy. We're training now in EMDR, in Target. So we're trying to bring evidence-based practices. That's one part of this work that we're doing. The school system is actually rolling out a 2-year plan to become a trauma-responsive school district, so that they're getting trained in identifying trauma and referring for treatment rather than calling the police and arresting. So there's a lot of work that's going on in Caddo and Shreveport. And frankly, the work with Dr. Wolfe and Dr. Bocchini and Dr. Farrell was the idea that we are lawyers and judges and don't know what we're doing. You are the medical community, you are the experts in this. So we're wanting to kind of tap into that expertise and learn from you. Have some of you, any of you that are interested in kind of the public health side, come to the juvenile court, tour juvenile detention, observe the way we do this, and tell us where we can improve. Tell us how we can do things that are better, more treatment focused than punishment focused, is the idea. That's kind of a broad brush, but anything else we should talk about?
Can I just make
Yeah.
absolutely quick comment? So I run a nonprofit called Step Forward, and we are a community partnership, and our job is to bring all these pieces together into a whole picture so that you know all that's going on in the community. We hear you loud and clear saying you don't know what resources are out there and you need a quick, reliable way to find that. Our organization's creating a website. It's traumainformedcommunities.org, I think is the address, but you'll get that link. It'll be launched next week, and I want to just say this disclaimer. Not every resource will be loaded on there next week, but it'll be a starting point. I want you to know a couple of things whenever you're thinking about referrals. Quality childcare was something that she mentioned. The availability of quality childcare to low-income families is there's a critical shortage. And when I say critical, what I mean is there's an estimate that 2% of at-risk infants are served by childcare assistance programming vouchers. That's a subsidy that a low-income family is eligible for to subsidize the extremely high cost of childcare. And there's not enough. There's just a fraction of CCAP vouchers available statewide and in this community as compared to families who need it. So the question that we have to ask ourselves is, where are those children? Well, they're in the next door. They're with the next door neighbor. They may be with grandmother, mom or dad, whomever may just not be able to work, but wants to work because of the lack of child care. So just know that there is a critical shortage of that resource in this community. We're going to give you all the information that we have about that and how families can apply for CCAP. Chances are they're going to go on a waiting list when they submit that application. So that's important to know. Another shortage in this community is crisis intervention services. We do have crisis providers locally, but not enough, and that's something we're going to work on for you, recruiting more providers that can go to the home and prevent a hospitalization for a mental health crisis. And so we want you to have that as an option as opposed to PEC if you would like to avoid that. So just wanted to mention that. The website should be up very quickly. We're excited about that. We want some feedback from you about what you need. If you see gaps in categories of services that you need to know about, we'd love to hear back from you about that. And you can get in touch with me easily through Dr. Bocchini, Dr. Cooper, Dr. Farrell, or you can just go to stepforwardnla.org and you can contact us through that website. So the last thing I want to say is you are all invited to a presentation on April 24th, and we really want you to be our special guests. It's at 8:30 in the morning. It's a breakfast. It will be 1 hour. There is no cost to attend, and we are going to be talking a lot about the community response to childhood trauma, and your work here and the project you have planned is going to be a highlight of that presentation. So as it develops, I'll be in close communication with Dr. Bocchini as that plan develops. We're going to hopefully have someone there to represent you, to talk about that on a panel. So I'm going to, while y'all wrap up, I'm going to pass out invitations to that event. Sign up on Eventbrite. The seating is limited and spaces are going quickly, but we would love to have a great representation of this medical community.
I'll be going to that on April 24th if anyone wants to jump in my car. Okay, so that was pretty much it. Here are my resources. Anybody have any questions? Yeah.
Okay, so going off what was kind of just discussed here, with some of the questions on this parental surveys being a little bit incriminating, and furthermore, just the act of seeking help sometimes can worsen or abuse situations at home, or at least, make people worry about that possibility. In clinic, what do you think are some things you can do to encourage parents to be forthright and honest with you?
That's kind of what we're trying to figure out, because a lot of these parents see a different resident every time they come in. They don't necessarily have that, warm, trusting relationship that you might have in a private pediatric office. So it may be something that we only do in continuity clinics. Those are the parents that we know really well, that we see over and over again. We're hoping we can do it to everybody, but I'm not sure we would get the right responses. Also, we need to make sure we're screening the right person. So, just because a woman comes with a kid doesn't mean that that's mom. It might be grandma, it might be paternal grandma, and we're asking things about, is the dad hitting the mom? So those are all tricky situations, and we've got very tricky social situations within the families that we see. So we haven't quite figured that part out yet. With older teenagers, we can screen them alone. We do our heads assessment without the parents in the room. So that kind of, once the kid's 11 or 12, you can ask the parents to step out of the room and ask the kids directly about their home situation. They're not always thinking about incriminating themselves or incriminating their parents as much. And like Laura was saying, we're not necessarily going to call CPS or call the cops for every yes answer. So kind of just have to offer your support. We got to figure this out still, basically. Dr. Gangor?
Thank you for the nice presentation and the nice comments from the other speakers. I would like to look at this also from a preventative perspective, just like many other things we do in medicine. It's great to know that we have resources and the screening tools, but I would like to turn the clock backwards and just start the care of these infants when they come back for their first clinic visit, and just to educate parents, and also probably to bring resources together to have some parenting classes on various aspects: infant nutrition, childhood nutrition, basic parenting, basic cooking skills, etc. So I hope we will see more effort in this in our communities in the near future, because I think prevention is the key, and that can truly help our children and communities.
Yeah, absolutely. Yeah, there's a lot of parenting classes, parenting support groups within that resource that Clay was showing us. So, and then we're going to have that lecture on the 23rd of this month from Renee Taylor. So those are some good resources we can use. There's also a lot of church-based resources. So a lot of them will, teach members of their church or non-members of their church, just people that need help, kind of basic life skills, how to play with your child, how to cook a meal for your child, all of that. So those resources are available, and there's a pretty good list in that juvenile court list. Any other questions? Yes?
I just have a comment. So for those of you who haven't done the new EPIC training, so while we're trying to figure all of this out, or even if you're not going to be doing this all the time, there is some screening questions on the new EPIC that ask about food insecurity, like, have you had trouble paying your bills this month? Have you had trouble, purchasing groceries, purchasing your medications and things like that? So that may just be, just while we're trying to figure all of this out, good for, our nurses to do, or for people that are in other clinics too, if it's something that you want to look into. The new Epic already has that kind of built in. So it's, it's a start while we're figuring it all out.
Yeah, definitely. And that's sort of been part of the question is, do these need to be part of those routine screening questions? Because they're pretty sensitive questions to just throw in there. Food insecurity is sensitive as well, but, we're asking about lead risk and all that stuff, and then we just throw in, and does your partner hit you? Like, do you hit your child? So that's kind of the question is, who's asking these questions and when within the relationship? So to be determined. And there's a big sense of, we have to, Dr. Farrell keeps telling me we have to walk before we run. So we might have to try several different things before we figure out what works in our community. So I'm only here for, I think it's 78 more days now. So hopefully one of the first or second years wants to kind of take this over and kind of become the champion of the ACEs. I'm looking at you, Patrice. So we'll figure it out. But this is going to be a long-term project for our program. All right. Any other questions? All right. Thanks, everybody.